testosterone is not magic. It's not perfect.
Whoa, now. Hey, now. Hey.
Hey guys, I'm Kristen Gumpf. I'm a physician assistant and I specialize in men's health. Here in the Men's Health Center, we commonly see patients with complaints of fatigue, low energy, low libido. And the question is, are these symptoms related to low testosterone? So today, Dr. Tatem and I are going to explore this topic a little bit more and see if this might be a good option for you. So Dr. Tatem, starting with the basics, what is testosterone? Why is it important?
Sure. So testosterone is a naturally occurring anabolic androgenic steroid. And so it is primarily made in the testicles in men, a little bit of the ovaries in women, and also in the adrenal glands. And testosterone is a steroid, which is a very particular type of hormone that has a 4-carbon ring structure. So there are multiple different types of steroids. Actually, what's most common is not anabolic androgenic steroids, but actually corticosteroids. So these would be things like inhaled nasal steroids for allergies, oral steroids like prednisone, or naturally occurring steroids like cortisol. And whereas those types of steroids, corticosteroids, help modulate stress response, increasing blood sugar, regulate inflammation. Anabolic androgenic steroids help regulate growing muscle, losing fat, also secondary male sex characteristics such as deepening of the voice, body hair, et cetera, as when, men go through puberty. And if you have a deficit of testosterone, it leads to some pretty significant side effects, like we all know, which involves low sex drive, maybe some erectile dysfunction, muscle loss, fat gain, and overall a sense of exhaustion, or the word we use in medicine is malaise, which is a very odd term, but just means tiredness. Okay.
And so testosterone, whenever you're saying steroids, I think especially whenever we're seeing new patients or patients for fertility, we ask them, have you ever taken steroids before? And so it's an important distinction whenever you're talking about anabolic steroids versus corticosteroids.
Yeah.
Very different roles.
Yeah, I think we see that most commonly in our fertility patients because we ask if they've taken steroids before and they get really nervous about their asthma inhaler. And I'm like, no, man, unless, your buddy was sticking you in the glute with your asthma inhaler at the end of a gym session, it's probably not that. Different things. Yeah.
And, with testosterone, a lot of guys also think that a lot of people in general, think that testosterone is so related to just sex and libido and erections, but it has a lot more jobs than just that.
Yeah. I mean, testosterone is essential for a healthy metabolism in both men and women. And, in our practice, obviously, we're limited to men, but we all need testosterone in order to live healthy, full lives, which is why it's important to make sure it's at a, normal level.
Yes. So speaking of that, we know what testosterone is. What is testosterone deficiency?
So testosterone deficiency is commonly known as low T hypogonadism, and this is a syndrome, which means that it isn't just a lab test showing a low testosterone level. It is the existence of a low testosterone level on testing combined with clinical symptoms. So I have met many patients, as have you, that may have low or even significantly low testosterone levels, but they feel fine. They don't really have any systemic issues. Whenever you ask them about loss of sex drive, loss of energy, erectile dysfunction, et cetera, they don't cite anything. And those men, despite having low testosterone levels, do not have the condition of hypogonadism. But when you have men who are experiencing fatigue, loss of sex drive, erectile dysfunction, fat gain, muscle loss, in addition to measurably low testosterone levels, that creates the clinical syndrome that is hypogonadism or testosterone deficiency.
Yeah, and it's interesting because then you can have the opposite with guys who have all the symptoms and then you check labs and they don't have low testosterone on labs too. Hormones are very complicated.
Exactly. And, there are a lot of things in life that can cause fatigue. And in a lot of consultations, I'll have guys who come in with all the symptoms of low T, but they've got normal numbers. They're like, doc, why am I so tired? And I tell them, I'm like, listen, there are a million different things. I have 2 small kids that don't let me sleep, and that's what makes me tired. Even though I'm a testosterone patient on testosterone, I know my levels are fine, but it doesn't matter. You got to think about other things like not just sleep, quality of sleep, exercise, all these other things that contribute to energy.
Very important. Yeah.
Yep.
So when should men, think about getting screened for low testosterone?
That's an interesting question. I really think that it is wise to get tested for low testosterone whenever you are experiencing those symptoms, all right, which can happen at any age, all right? It's totally reasonable to get checked. And I think that it is also reasonable for younger men that maybe they feel fine, they just want to have an idea of where they are. I have a lot of guys who approach me, out in my personal life, are like, hey, when should I get tested? I was like, if you want to get tested now just to know where you're at, that's totally fine. You don't have to do anything with that, but it's information. Patients that I think really should make it a priority to get screened are men that are over the age of 40 that are starting to experience those symptoms though, okay? Or they have a specific risk factor. Like let's say they're diabetic, they have a history of opioid use, metabolic disorders, transplant patients. These are all people that have an elevated risk for hypogonadism, and we know they do much better whenever their testosterone's at a normal level. So they have a really strong case to benefit from testosterone therapy.
Yeah. And what labs are you typically ordering then?
Sure. Well, obviously we're pretty comprehensive, here at our clinic, and we probably get more labs than what most places do. But the bare minimum screening that you need to get is 2 early morning testosterone levels. And the reason why timing matters is because testosterone is secreted on what's called a circadian rhythm, or follows a diurnal pattern. And so this means that it changes with the hour of the day. So testosterone levels really need to be drawn before maybe 11 a.m. noon, because testosterone levels will drop later in the afternoon. Now, that response of that dropping in the afternoon tends to be blunted in older men, so it really doesn't make as big of a difference. But for our younger patients, they're almost universally going to have low testosterone levels in the afternoon, and that's normal and actually healthy. So we have to look at what it happens first thing in the morning. Yeah. Other things that I do think are worth mentioning, I think it's helpful to check estrogen levels, hematocrit. We check gonadotropins, FSH, LH. We'll also screen with a prolactin to rule out the presence of some sort of benign growth that may be affecting testosterone levels. And really it can go on from there. Some places will do a comprehensive metabolic workup in addition to testosterone levels. So but the bare minimum is getting those 2 early morning testosterone draws.
And so different types of labs, you have your total testosterone and free testosterone. So what's the difference there?
Yeah, well, it's kind of funny because biologically, like the only testosterone that actually matters is free testosterone. Yet we don't routinely use that for screening. And that's actually a bit of a flaw in the published scientific data. Because if you look at it, what happens to testosterone in the body is that the majority of testosterone, maybe 98% of it, is actually bound by 2 proteins, sex hormone binding globulin primarily, and then to a lesser extent, albumin. And whenever testosterone is bound to protein, it can't be metabolically active. It's not free to bind to the androgen receptor and exert its terminal effect, which is changing transcription of proteins in the cell nucleus. So in reality, it's that free testosterone that matters. But no one can really agree on the best way to measure free testosterone. The gold standard is this really complex test called equilibrium dialysis, which nobody actually does in clinical practice because it's so challenging to do and very time consuming. And so most people will use a calculated free testosterone. But when all of the original studies were done trying to establish the thresholds for low testosterone and average testosterone levels across the population, that wasn't done, right? It's more expensive to do that. So everything was measured against total testosterone. So we don't really have established really good thresholds for free testosterone. Many have been proposed. And there's a lot of data that you can find that may support one versus another, but the majority of the thresholds that are in guidelines are all based on total testosterone. So in our clinic, we will gather both total testosterone and free testosterone because, at least in our clinical opinion, we believe free testosterone can be a useful differentiator whenever men are kind of at that borderline, like let's say a testosterone of 420, something like that, but they still have significant symptoms. If they've got a low free T, that's probably someone that would benefit from testosterone therapy.
Yeah. These are always interesting conversations to have with other providers too.
Yeah.
I think, talking about total and free and sex hormone binding globulin and things that can change that and bind more testosterone and everything. So change, and in practice, it's kind
Yeah.
of difficult to know how to take that or how much weight to put on one versus another. And it's,
Yeah.
in the end, it's just not perfect, which very few things in medicine are perfect. So.
Yeah. And I think it's helpful to be honest with patients about that.
Oh, yeah.
And just, tell them, say, hey, you've got a lot of symptoms that are consistent with low testosterone, but really your total testosterone isn't adding up, and you're free, although it may be low, let's say by percentage. Okay. Your total testosterone's 850, man. I feel pretty confident that testosterone is not the reason you're tired. Okay. Maybe, right?
It's interesting, scenarios where you can see kind of a low testosterone too. Or low free testosterone. A recent patient who had undergone chemotherapy, and maybe that can have some effects on the liver and change sex hormone binding globulin and that free testosterone. So there are certain scenarios, but that's not your typical everyday low testosterone patient that you're seeing.
Yeah. And, again, there's a reason why we have to get two measurements. I think I told you the story recently where I had a supremely healthy young 17-year-old, kid coming in with a scary low total testosterone of 90. I look at him, and the kid is in fantastic shape. He's just jacked out of his mind, and he's talking about hitting all of these plateaus in the gym, and he's just tired, and he denied any prior anabolic use, never used SARMs or anything like that. And my suspicion is I just think this kid is overtraining, and so gave him a week off, and which was a very painful week for him. And then he comes back with a repeat set of labs, and he's stone cold normal. And the truth is that he wasn't giving his body time to rest, and that's why he was feeling so dadgum drained. And once we got him set up with something that was a little bit more reasonable, he started to actually progress and feel much better.
Yeah, and that's an interesting one. I've never seen that firsthand in a patient.
Yeah.
And it's always so many things in life are a balance, because we talk about exercise being beneficial for testosterone too, but anything that's done too much maybe isn't good.
So if a guy comes into the clinic and they are concerned that they have low testosterone, for you, what does that conversation look like, and what is that patient journey, going to look like moving forward?
Yeah, so different options. I mean, some guys come in and they've never been tested before, and they have these symptoms, and they're just interested in getting tested and seeing what those options are. Other guys have had a testosterone checked with their primary care or something, and it was low or borderline, and so then they're coming to us again to talk about what does this mean and what are my treatment options. Some guys used to be on testosterone and for whatever reason went off of it for a while and want to get back on it. So a lot of different places where you can start, but then it's all, again, reviewing what symptoms are you having? Have you taken any type of steroids before? How long have you been on them or off of them? But also a big important question is fertility. If they're interested in preserving fertility. And I've unfortunately seen guys who have gone to a low T clinic before or something, and they were started on testosterone, never told about the relationship with testosterone and fertility. And, I had a guy who we checked a semen analysis, and he had 0 sperm.
Yeah.
And, so that's a very important place to start, because then if they have low testosterone, it's going to be different treatment plans for guys who want to preserve fertility versus guys who don't. So definitely getting a good history on your patients is always important. And then if they have low testosterone, talking about your different treatment options, which a lot of different options there, and you just kind of, have that conversation and figure out what's best for that patient.
Yeah. I think it's really good that you brought up the issue of fertility, because I just got a message today from a patient asking about how they could improve their fertility, and they asked if starting on testosterone would help out their numbers. And what's a little spooky is that that misconception doesn't just come from patients. There are a lot of doctors out there that think that testosterone boosts fertility, when in reality it does the exact opposite. Yeah. I mean, the way that I explain it to patients is that your testicles only have two jobs: make testosterone and make sperm. And whenever your body sees a lot of testosterone in your circulatory system, it just says, hey, I mean, I don't have to do my job anymore, right? And it just
Sit back and
completely,
relax.
yeah, sit back and relax, totally shuts down. And as a result, your pituitary stops making the FSH and LH that your testicles need in order to be stimulated. So it's kind of like you just give up on watering a plant. Like, yeah, you could probably get away with that for, a couple days, maybe a week or two, but you're pretty soon going to have some significant side effects, which is why men who have been on testosterone for a long period of time, if they're not on something additional like HCG, they're going to notice actually atrophy and shrinkage of the testicles. Okay. All right. Let it be known that testosterone does not shrink your penis, but it will shrink your testicles if you are not on some sort of adjuvant therapy. And the AUA guidelines even explicitly state that if you are trying to get pregnant, that you should not be on testosterone therapy. There's some nuance there. There are some ways that you can work around. Yeah, you can, obviously in our practice, we can talk about like using HCG at the same time with gonadotropins like FSH, the benefit of like oral testosterone, short-acting oral testosterone within clomiphene. But generally speaking, testosterone and fertility don't mix very well. Yeah. So if a guy is diagnosed with low testosterone, okay, what are his treatment options?
So generally you have topical testosterone that can be gels, creams, used to be patches. Really, patches aren't available anymore. Injectable testosterone, which tends to be the most common option, both from like a cost and convenience standpoint. You have oral testosterone, a few different options there. You have Testapel, which is like a slow release pellet. It's an in-office procedure. You have long-acting injections that are again in office. And so, coming to a decision on treatment is kind of a analysis of cost, convenience, needle phobia, different things that go into that too. And there's not one right answer for everybody. So that's whenever you're talking about testosterone, and then there's kind of different options that we talk about for treatment of low testosterone guys who want to preserve fertility, mainly like Clomid.
Yeah. And so what do you tell patients that say that, oh, well, I want to try testosterone, for a little bit and just see how it goes, right? Like, I just want to, maybe I'll dabble in it for a little bit. And, what does that conversation look like?
And they're not interested in fertility, right?
Let's say they're not interested in fertility.
Okay.
Yeah.
So, if they have low testosterone, they have symptoms, I kind of start that conversation of like, yeah, we start you on testosterone. We see how you feel. We see what your numbers look like. And you want to give your body a few months to kind of acclimate to those numbers and see how your symptoms change. And worst case scenarios, if you don't like it or it doesn't have the change that you anticipated, you can stop after a few months. So honestly, like trial period kind of stuff is fine. I talk about that. In general, you have to have reasonable expectations whenever it comes to testosterone, in such that most guys who start it is a forever kind of treatment. It's not like, hey, go on this for 6 months. It's going to fix you and then you can go off of it. Once you're on it, if you have benefits from it, then you stay on it. Which most guys don't care too much, because if you had symptoms prior and then you feel better on it, you want to continue. So, but it's just, I come at that conversation of being like, testosterone is not magic. It's not perfect.
Whoa, now.
I like these conversations a lot, because I never want to sell something that's like, this is going to fix your life, right? It might be an important part. It's still a part. You have to get good sleep, exercise, diet. You have to take care of your no. You have to take care of your other medical conditions. And yes, testosterone helps stabilize your blood sugar or something like that. But it's just, you have to be focusing on all these other things too.
Yeah.
And so it's just, yeah, it's not magic.
Yeah.
It might be helpful, but have reasonable expectations.
I think the only, testosterone is not a silver bullet in of itself. And I think the times in our clinic where we see those sort of magical silver bullet moments are actually when we have patients who have already done everything when it comes to their diet, their sleep, their exercise, and they still aren't improving. And it turns out that they just have a hormonal imbalance that isn't responding to conservative interventions, right?
Oh, sure.
And that's just the missing piece of the puzzle. But they have all the other pieces together.
Yeah.
Then we also
There's plenty of times where you start people on testosterone, they feel a lot better. Yes, it's definitely, we want it to have that impact.
Yeah. But we've also seen patients that think that starting on testosterone is, going to make them look like Chris Bumstead, right?
Mm-hmm.
And we're like, I know
man, who that is.
Yeah, right. Like, there you go, right? That's the one thing we're missing in our new office. Like, we have this beautiful new building, and we don't have a single Arnold poster here, like unlike our old office. Yeah. So yeah. But talking about like sort of lifestyle interventions, if a patient, comes in, let's say they're borderline or they're borderline low, and, they're really just not ready to start testosterone therapy. Maybe it's, January, new year, new you. They're like, what can I do to improve my testosterone numbers naturally? What options do those patients have?
Yeah. And it's, some guys, it is kind of daunting whenever you say, hey, you're going to start on this and then probably take it for forever.
Yeah.
And so sometimes that alone is like, oh, okay, give me a second. Let me think about it. Or, maybe let's recheck it in 6 months. But in that period of time, what can you do is focus on exercise, movement, resistance exercises, typically giving you your best change in testosterone. But you can boost your own testosterone, by exercising.
Yeah.
And diet, very important. Foods that are high in zinc, vitamin D can help to boost the testosterone. You really want to focus on whole foods and, just generally kind of avoiding processed or prepackaged kind of foods.
If it comes in a can, a box, or a drive-through, you probably shouldn't be eating it.
I know. I heard you say this the other day, and my only question is can.
Canned?
Yeah.
Canned is just my blanket statement for like the canned sweet potatoes. I seem that everyone has in the back of their, their pantry somewhere. But, the way I try to tell patients is like, if you want to make life easy for yourself, like your food should have an expiration date, right? It shouldn't be, something that's supposed to live in perpetuity, because generally food doesn't do that.
Yeah.
So, if you're not going to the grocery store twice a week to get like fresh veggies or fresh meat, then, maybe you want to look at that.
That makes sense. Yeah.
Yeah.
Vitamin D is another important nutrient that you want to be looking at. And
that none of us get in the state of Indiana.
Exactly.
Yeah.
So yeah, that's kind of a combination of weather and diet. And ideally, you're getting these balanced micronutrients from your diet. Sure, there's supplements, there's vitamins, all that kind of stuff that you can take too.
Yeah.
You don't want to rely on that necessarily. But, so vitamin D is something you classically get from sunlight. We have very little of that. And so having that checked and trying to increase that in your diet. But some guys have crazy low vitamin D, whenever you check it. And so sometimes you have to do a prescription strength vitamin D for a period of time, which is a pretty high dose.
Yeah.
And then there are some other supplements that you can look at for testosterone that may have beneficial impact. So boron being one. I don't have too many guys asking about that one specifically, but I do have a decent amount of patients who ask about ashwagandha or Tongkat Ali.
Yeah.
And those are two other supplements that, could have benefits with the testosterone.
Yeah. Out of all of the things that have, hit the market, lately, we've known about like vitamin D for a really long time, same with boron, zinc, but Tongkat Ali and ashwagandha have probably been the most promising because they really do make a measurable difference in serum levels. Now, there's a question of how long you can stay on those, and there's some big question marks there. But I think it's very reasonable for patients to take those for a period of, let's say, 2 to 3 months, trying to boost their testosterone levels naturally as they make other lifestyle interventions, and kind of use that as a catalyst to make healthier life choices.
Yeah.
But what do we do for, or what are some options for patients that, let's say the lifestyle interventions haven't worked for them, but they don't want to jump on testosterone just yet. What are some other therapies that we can offer to help men make more of their own testosterone?
So the first go-to usually for me is Clomid or enclomiphene citrate. That medication is FDA approved in females, typically used in like fertility cases, and it's very different the use in males versus females. So in females, they're usually only allowed to be on it for a period of time whenever you're going through a cycle of IUI or IVF or something like that. Whereas for guys, you can use it longer term. They have longer term safety data on it. And so how that works, it's what's called a SERM, a selective estrogen receptor modulator. And so it kind of blocks your estrogen receptor. So your brain thinks that it's low. It increases your LH and FSH, which stimulates your testicles to make more testosterone and sperm. So sometimes we use that in testosterone cases, sometimes in fertility cases. It's very well tolerated, from like a side effect standpoint or anything. It might have more of an impact on estrogen levels than you see with testosterone, but that's something that we check all the time anyway. Anything that we do to increase your testosterone can increase estrogen. And so still monitoring those labs. And so that's, getting your body to make more of its own testosterone. Then we see, how do your levels respond? Can your body make more of its own testosterone with that? And how do your symptoms respond to that too? I think this is another very interesting conversation whenever you're talking about testosterone levels on Clomid versus testosterone levels on testosterone.
They are not the same thing.
They're not the same, which is so interesting. And and what we mean by that is you could have two guys with the same numbers. One is on Clomid and one is on testosterone. And they had very different symptom changes or non-symptom changes.
Which I think that just speaks to the importance of estrogen in men, just like testosterone is important in women. Like, we need both of them. And I think we've also seen patients in our practice who we've started on, let's say, an aromatase inhibitor, an AI, like anastrozole, trying to bring an estrogen that's too high down. We overshoot and get it down to zero. And sometimes, not always, but sometimes those patients will report low T-like symptoms, and they'll report some sexual dysfunction related,
fatigue and libido
related to what we believe is their low estrogen. So there's definitely some nuance there. I think it's worth throwing out there that enclomiphene has kind of been hailed as the new holy grail of kind of performance enhancement light, in the sense, because it is this version of Clomid that arguably has all the benefits of Clomid, but doesn't have some of the less desirable metabolic byproducts, and supposedly isn't as estrogenic. And I think that we've learned from clinical practice that if it is less estrogenic than Clomid, classic clomiphene citrate, only by a very small margin.
Very slight,
Very slight,
If anything is being sold as a holy grail, maybe it's not. Right?
Maybe not. I don't think that there really is like a single holy grail, because really it's just, it's trying to match the right therapy for the right patient and the right dose, and, try to get somebody in a good rhythm. And we've seen that change over time. Right?
You talked about aromatase inhibitors too. So again, that those are safe for fertility. We use those most commonly in conjunction with other treatment. So if people are on Clomid or enclomiphene, if the estrogen's too high, you can use an aromatase inhibitor like an anastrozole to bring that down some. Like you said, you want to make sure you're not doing too much. You still want guys to have a normal level estrogen, but not too high. If it's too high, you can get symptoms of nipple sensitivity, joint pain, more difficulty with erections. But at the same time, you don't want it to bottom out either. Not usually using aromatase inhibitors like for monotherapy necessarily. I mean, you could if somebody has like a really high estrogen and a normal testosterone, but I don't see that all that often. Usually
Not
it's
common.
Combination. HCG, human chorionic gonadotropin,
which is
say that
not
10 times
HGH.
fast.
Okay.
Not HGH.
How many
not human
patients?
growth hormone.
How many patients in a day do you say we're going to start you on HCG, and they're like, "Oh, you're going to start me on HGH," and I'm like, "No, bro, no."
Those are your patient visits, not mine. So HCG is an injectable medication, and it's pretty much like injecting LH. And so again, giving your testicles that signal to make more testosterone. And then oral testosterone, newer option for testosterone, but has some promising data at this point potentially in regards to fertility, maybe similar to a nasal testosterone option that was on the market.
That was on the market. I don't even know. Can you even get Natesto anymore?
I've actually never prescribed it.
You haven't?
Never?
Yeah, I think I tried like a handful of times, but what happened is the rep at the time brought it in and they're like, oh, we've got like a model that you can train patients with, or you can try it yourself. And I tried it and it was so gross. I felt like I had a runny nose the rest of the afternoon.
Yeah.
And so, I think that's probably why we don't see nasal testosterone
And 3 times
anymore.
a day was always a tough sell too. So.
Yeah. I mean, I do know that it's interesting to use for people that are looking for a temporary boost in testosterone, like prior to intimacy, with a partner. And it's actually been shown to be very safe to use that in that context, and it actually works very well in women. Interesting. And I know some people that have used it in the performance enhancement world, like before going for like a really hard workout or a big lift. But I don't see anybody using Natesto as monotherapy anymore.
No. But this is another thing that's just really interesting whenever you're talking to other medical professionals about Natesto or oral testosterone, because it's the types of, we can get into the types of testosterone treatment specifics at a later time, but, half-life of different medications and just, how they exert their effects. It's very interesting, and why then that has either different side effects or different impacts on fertility and everything.
Yeah. And we will save that for a later podcast where you will probably have to pull me out of every rabbit hole that I want to dive down on, the structure of one.
Stay out of those
one
rabbit
ester
holes.
versus another. Yeah.
So then, if you have guys starting on testosterone, what do you generally look for improvements after starting?
The number one thing is improvements in energy levels, just feeling more vitality throughout the day, which is super vague, right? What does vitality mean? What does energy mean? But patients who respond well to testosterone, you ask them that question and their eyes light up and they're like, absolutely, I feel so much more energetic. I feel like myself again. Another one is, increase libido, so increase interest in sex. Also, just better recovery after workouts. Guys feel like they can get back into the gym the next day or the day after that, as opposed to, I think this is something that I've experienced. I'm older than you, but whenever you work out and you're like, maybe maybe next week, right? You're struggling, for a couple of days, you're still limping around. And the benefit of testosterone therapy is that you get stimulation of the androgen receptor and you're going to bounce back a lot faster. And some of the things that have, been mentioned commonly, there's some conflicting data on this, but better mood, better mental clarity, a lot of men will report, and maybe that's just related back to the, better energy levels.
Yeah, maybe. But again, those are complicated symptoms that you're talking about, because you can still have a bad day on testosterone.
Oh yeah.
Work can still suck on testosterone.
Absolutely. Yeah.
Your relationship can be complicated on testosterone. So.
Despite being on testosterone, I still have a lot of really crummy emails to answer every single day.
Yeah.
And it has not changed that. And usually, how long do you wait before you see patients back to see if they're really getting a benefit from testosterone therapy?
So I start them on testosterone, and then I do a follow-up 6 to 8 weeks after starting.
Yeah.
But still at that visit, it might be like, I think maybe a little bit better, and if their labs are okay and we're not making huge changes, then I usually do a 3-month follow-up thereafter. And again, repeat labs and ask about symptoms. So, but I also tell them it's not like as soon as you start testosterone that it's this boom, your levels are up and you feel amazing. It can take like a month usually before you're seeing kind of those changes in symptoms for most guys. Other guys kind of get this initial peak that they feel amazing, and then it stabilizes out to kind of normal. So Again, hormones are complicated, and it's just interesting to see the differences between patients. But generally, that's the time frame. And then long term, once you're stable, seeing patients twice a year with labs and to do refills and everything.
Yeah, yeah, and that's an important, technical thing to mention is that testosterone in the United States is a Schedule III substance, which means that its use is monitored by the DEA, and so we are actually obligated by law to renew that script, within 6 months, which means, at least in our practice, we need to check in with you, see you again. We like to get repeat labs, make sure that we're still stable where we need to be, and that sort of thing.
Oh, yeah.
So, if it's been longer than 6 months, right? Like it's kind of hard to risk running afoul of the DEA to write another script if you haven't seen a patient in a long time.
Exactly.
So
it's a small thing to have a visit twice a year to make sure that things are safe, right? And I tell guys, like, testosterone is very safe as long as it's managed and monitored properly.
Yeah, yeah. Which I think gets to the point of why it's important, if you're going to try testosterone, if you are interested in this, go see a doctor. Like, actually get tested, because you could run into so many obstacles and problems if you just start taking testosterone on your own. Because testosterone, although extremely safe when monitored by a provider who's well versed in testosterone therapy, you start taking it on your own, and you're going to catch side effects. It's just a matter of what and when.
So talking about side effects,
Sure.
what do you typically see, or what do you talk to patients about?
Yeah, I mean, not that I would know anything about this, but hair loss tends to be a bit of an issue in some people. But, really, the things that we look for first are like the safety checks, right? So we are going to monitor your blood thickness, okay? We're going to, through a hematocrit check, we're going to be measuring your estrogen levels to make sure we're not getting too much aromatization, conversion into estrogen, which can have, its own bad side effects when that gets out of control. And, we also, talk about things like, hey, this is, affecting fertility, making sure that we're all on the same page. And after that, we start to get into probably I don't want to say smaller side effects, but things that can be bothersome to patients, but aren't maybe an imminent threat to, their well-being. So that is hair loss, increased oil production. So, acne can be a common thing, especially on the shoulders and the back. And other small things. Some people will report some mood changes when they start on testosterone. And, although I don't think that true testosterone therapy ever results in roid rage, but, we have had, some patients, when we're trying to dial in that dose, report, some changes in mood. And so that's important to keep track of and to be aware of. So
fluid retention. Water retention, you see a little bit of that?
A little bit of that, that can happen more commonly with the injectables. Kind of the longer the half-life of your testosterone therapy, the more likely you're going to hold on to a little bit of fluid, especially with higher doses. So some people would argue that's why, maybe a shorter ester product like a Nanthate might have a lower bit of fluid retention than cypionate, but I'll start to go down a rabbit hole here. So that's another one to keep in mind. The two things that we have to emphasize to patients, though, is that although we do check PSA or prostate specific antigen in many of our patients, testosterone does not cause prostate cancer. Okay. The prostate is a gland that sits in front of the bladder that's responsible for making some of the fluid involved in ejaculation, mostly liquefying it. And, the prostate is this organ in guys that's like your hair or your fingernails, keeps growing forever as long as you're alive. And it can cause problems in one of two ways. The first is BPH, or benign prostatic hyperplasia, which is where the prostate gets larger and ends up obstructing the flow of urine. And if you live long enough as a guy, you're going to end up experiencing that eventually. We've all got that awaiting us in the future, right? But the other way is prostate cancer, which is one of the most treatable forms of cancer, but it's also one of the most common. Again, if you live long enough as a guy, there's a good chance you might develop prostate cancer. And we know that because the prostate is dependent on testosterone, again, as a metabolic signal, if you take away testosterone, prostates shrink, we know that for men that have metastatic prostate cancer, so metastatic meaning that the cancer has left the prostate, the chickens, already left the roost, that we can take away all testosterone and we can starve out those cancerous prostate cancer cells. But we've done countless studies and found that men that are on testosterone do not have an increased incidence of developing prostate cancer, and they do not have an increased incidence of more aggressive prostate cancer. So it used to be maybe years ago that cancer surgeons would want their patients already on testosterone if they were diagnosed with prostate cancer to stop their testosterone. And now we're getting to a point where if we've proven that you don't have prostate cancer outside of the prostate, we'll maintain a lot of patients on their testosterone as they go through prostate cancer treatment, like surgery, unless they have a very advanced form that necessitates androgen deprivation along with something like radiation, which are, again, not the most common presentation.
Yeah, and prostate cancer is very interesting because there's a wide range of what prostate cancer can be. You can have low volume, low grade prostate cancer that you are just having patients on active surveillance, which means they are not being treated for their cancer and you just watch it.
Yeah.
And they might be able to go their whole life with just that. Versus very aggressive types of prostate cancer, which require surgery, radiation, maybe other oral therapies or injectable therapies too. And so, but whenever you think about it the opposite way too, if you have a guy who's diagnosed with prostate cancer and he's just a guy who has normal testosterone, he's not on therapy, well, for the most part, you're not looking at bringing testosterone down in those patients.
Yes.
Again, it's a small subset of guys who then go on androgen deprivation therapy to bring down your testosterone, but otherwise you leave it be. And so same for these guys, we can just kind of leave it be. And over time, the progression of research in prostate cancer and the relationship between prostate cancer and testosterone has come a long, long way. So.
Yeah. I get a lot of calls from my colleagues, who are treating prostate cancer patients, and, they'll ask, is it safe to restart their testosterone? And, I think that people try to overcomplicate it, and they try to give all of these caveats. And I just make it really simple. I'm like, is this man's prostate cancer so severe to the point that you would need to castrate him, that you would need to cut off his testicles? Because believe it or not, that's what we used to do in urology.
Yeah.
We used to actually do it in clinic, as terrifying as that is. Not me, other urologists. I would never do that.
This was before your time.
It was before my time. Yeah. I'm not that old. Where urologists would actually remove men's testicles in clinic. They would do in clinic what's called simple orchiectomies, remove the testicles, because that way you could drop the testosterone as quickly as possible. And again, that sounds pretty gruesome, but that's what happens whenever you deny a man his testosterone. It's pretty gruesome. And so if a man's cancer isn't to the point that you would even entertain doing something that gruesome to him, well, guess what? He deserves to have a normal testosterone. And if he has to get that normal testosterone through testosterone therapy, well, it's like, so be it, right?
Yeah.
Not that there's no reason why we should deny him, but a guy who has a normal testosterone gets to rock along with his T of like 650, right? That's not fair.
Yeah. Quality of life is important.
True.
Along with quantity.
Yes.
What about cardiac risk factors?
Yeah, so this has been a really hot button topic for years. There were basically a number of trials that came out many years ago that said that testosterone increased the risk of heart attacks. And this was, really a, red alert, red alarm for people everywhere when it came to prescribing testosterone therapy. And it really set testosterone therapy and a lot of men's quality of lives, back, for a long time. It later came out that data was extremely contaminated. And in the data set, they actually had female patients, and they had in the control set, which was not supposed to be eating testosterone, they had men on testosterone. And in the treatment arm, they had men that were supposed to be on testosterone but weren't. And essentially
super accurate.
Yeah. And so unfortunately, there's never been a formal retraction of those studies. But since then, we've had a lot of really well done trials. The most recent being done being the Traverse trial that looked at testosterone cream and gels, and how did topical testosterone, increase or decrease cardiac risk. What we found is that although, there was no increased evidence of major cardiac events in men on testosterone, men who had low testosterone that didn't get it treated, they were more likely to have a heart attack. So in reality, if you need testosterone, it's safer to be on testosterone than not, okay? Testosterone does not have a proven detriment to cardiac health, at least within the setting of prescribed testosterone therapy. All right, that doesn't include what some people take on their own, what some people will take in the gym. That doesn't include, other anabolics. All right, at super physiologic doses. But if you are receiving testosterone from a qualified provider, there is no evidence that that increases your cardiac risk. So research should be done. Traverse was looking at gels and creams. It wasn't looking at injections. But everything we've seen has been incredibly reassuring.
Yes, but also to hammer home why research is so important, and can really have a big impact for years and years and years to come. Whenever previously it was that everyone gets really nervous to prescribe it, so then guys aren't getting it. And an interesting comparison is estrogen therapy in females, and black box warnings on that from previous studies. And so it's important to research this more and to get concrete data so that you can back things up for either coverage of medications or just helping patients feel comfortable knowing that it's the right choice for them. But, so along those lines, lots of options for testosterone therapy, lots to consider. So in a future video, we're going to talk more specifically about different treatment options and, trying to figure out what's best for you.
Absolutely. Looking forward to it.
All right. Bye.
See ya.